Welcome to the PD Exchange, a podcast where we bring you the best of peritoneal dialysis. I am your host, Dr. Nikhil Shah, a nephrologist at the University of Alberta, Edmonton, Canada, and with me is my co host, Dr. Jeff Perl from the St. Michael's Hospital in Toronto, Canada. Dr. Perl is a nephrologist and is the editor in chief of the journal Peritoneal Dialysis International. Today, you are in for a special treat as we bring you a touch of madness to this podcast. This is NephMadness episode of the PD Exchange. Jeff and I welcome the one and only Dr. Matthew Sparks, a nephrologist, a basic scientist, and associate professor at the Duke University. While Dr. Sparks wears many caps, including being the program director of the fellowship program at Duke, he's perhaps most well known by his Twitter handle, NephroSparks. He is a pioneer in the use of social media to enhance nephrology medical education. He is also on the board of directors of NephJC and founding member of the Nephrology Social Media Collective, NSMC, and relevant to this podcast, the creator of NephMadness. Along with Matt is Dr. Timothy Hopper, a nephrology fellow at Duke University, and his special interests include providing dialysis for patients at home and the EPOIN-related kidney diseases. Welcome, Matt and Tim, to the podcast. Jeff?
Yeah, and it's really exciting to have this podcast. I think the madness part for me about NephMadness was not knowing exactly what it was. And Tim, thank you for spending probably a good 45 minutes to explain the whole concept of NephMadness, which is really exciting. And so it's great to finally see home dialysis participate as part of the NephMadness madness.
Yeah, it was a little tricky for me too at first. You should have gone right to Dr. Sparks, the pioneer.
Yeah, so, Dr. Sparks, Pat, can you explain our listeners what is NephMadness?
Well, first of all, thank you so much for having me. I'm so honored and thrilled to be on this podcast and also to be with Nikhil. He was very first graduate of our internship program for the Nephrology Social Media Collective. NephMadness was really born of an idea that we can share and educate in a fun and engaging manner. So I was a co-creator with Joel Toff. I think we're now, try to think about this. I believe we're in our either 12th or 13th year. And what we tried to model this is after the United States college basketball tournament called March Madness. It happens every March. It's kind of nice because in springtime and everyone's finally getting out of that cold Canadian winter. Wait, you might always have a winter. But it's kind of like everyone comes together and watches sports. And in this case, we talk about nephrology. And every single region has a team that plays each other. And we tried to riff off things. And so we have regions. And so in this region, it's the peritoneal dialysis region. And we have two fantastic teams that are going up against each other in a sort of make-believe match. We have a blue ribbon panel of judges that pick the winner, and we have an odd number so they can kind of feel out which one's the best. And we tell them which concept will have the biggest impact on patient care in the next 5 to 10 years. So in this case, we have two teams, one called PD First, and the other one that is beyond KT over V. Tim did an excellent job writing up this draft with expert opinion from Jeff Perl and also from Janice Lee from Emory. And so sort of try to figure out what are the salient details about each of these topics, which we'll go into more detail in this podcast. So the Blue Ribbon panel decides which one of those concepts is the winner. And then the whole community also looks to see what they think. And then we see who matches up with the Blue Ribbon panel, and that is the winner of that matchup. And this is done across all of NephMadness. We have 8 different matchups or 16 concepts that we talked about, and this is the peritoneal dialysis region. And we have a lot of fun. We talk about, we have a thing called Blue Ribbon Fail, when the Blue Ribbon panel picks something that's wrong or we believe is wrong. Because really there can't be a real winner or loser here. And it's all about debate and passion and rooting for your team. So with that, let's get to the good stuff and talk about peritoneal dialysis, which, is a really important topic. A little bit nervous here to be talking to two Canadians that are leaders in the field. as an American who is really trying to just scratch the surface, and a program director is really working hard to teach this to all the fellows and immerse them in it themselves in it. I can't wait to learn from some masters of PD. So Tim, why don't you go ahead and kick us off with the first topic, PD first. And I'll also say Tim had a lot of effort in thinking about what these teams will be, and so I want to hear about why he picked these two as well.
All right. Yeah. Well, yeah. Thank you to all of you guys for all of the help that you've already provided on this. But jumping right into it, we thought it would be useful to break it up into these two categories just to kind of focus on different aspects of how we're trying to broaden access to peritoneal and really home dialysis more broadly. But we, just for the sake of focus, kind of zeroed in on PD for this regional. The big picture is that we all know that there's this huge move towards broadening access to home dialysis in the US, and that we've set out really, really lofty goals, like the Advancing American Kidney Health Initiative wanting to have 80% by 2025 doing transplant or home modalities, which I think we all realize is aspirational to say the least. But it has that goal has definitely spurred some innovation and caused us to rethink how we're deciding what modalities people should do. So the PD first region kind of starts at the origin of thinking about how about 45% of patients in a broad study indicated that they would like to start with PD, but in reality, only about 13% of them were ending up starting on PD in the US. And there are a lot of reasons for that. So I wanted to go through, kind of analyze what those structural barriers were, and then really focus my attention on how we can address those and how they have addressed those effectively in some other systems. Those were the kind of the big picture categories that I wanted to focus on. Were learning a little bit more about incremental PD, looking at urgent start programs, and then things we can do to make things practically easier with the way that we place our catheters, and if that is going to provide comparable outcomes to the traditional way of doing things.
Yeah, and that's such an important topic, PD first. And when we have an international audience here at the PD Exchange podcast, and in some countries, what PD first means is that it's sort of a government policy where PD is the first reimbursed therapy among patients eligible for both therapies, which has been highly successful in environments like in Hong Kong and under certain insurance schemes in Mexico. And historically, although this may be changing, a PD first policy in Thailand. And I think we have to look at why for so many years we defaulted to in-center hemodialysis as the initial therapy for many of our patients. And Tim, as you highlighted, I think PD is having a moment, as my colleague Joanne Bargman says, in the United States. We have the Advancing American Kidney Health Initiative, which, whether you agree with those goals of 80% or not, are achievable, still has the whole idea that we should empower our patients to grow the use of home therapy and kidney transplantation. And we've created a reimbursement structure that's completely different, that for years actually disincentivized the use of PD and incentivized the use of in-center hemo. So I think we have to unlearn these years and years of the fact that for many years that was the default therapy. And that's the therapy that many nephrologists only know about and have only managed patients. So I would say, from a barrier perspective, it's all about education and initiatives like this, like NephMadness, that bring awareness to this. We really need to make sure that our nephrologists in the future know about how to manage patients on PD and how to start patients on PD if that's their chosen modality. Rob Rope did a survey published in JASN several years ago about nephrology fellows coming out of fellowship, asking them, what they felt were topics that were they could have learned more about or they could have been exposed more to. And in fact, home dialysis were one of the top two topics that fellows felt uncomfortable with. So I think there's great initiatives, being led by the ASN, for example, with Home Dialysis University that has fellows coming and learning about home therapies and then participating through an ASN scholarship with a curriculum to be able to learn about home dialysis through a virtual mentorship series. Some really exciting initiatives. So I'd say one big barrier is education. And hopefully our nephrologists and our nephrology trainees who will be the nephrologists of the future will really have much more comfort with prescribing PD. Because guess what? If you're not comfortable with something, you're not going to prescribe it. And there's also so much bias that exists in nephrologist perspectives around home dialysis. We did a survey, and we surveyed medical directors of hemodialysis programs and medical directors of PD programs, just giving them scenarios like if a patient had PKD, or if a patient lived alone, or if a patient had a physical disability, how likely would you or would you not to prescribe PD? And no surprise, medical directors of PD programs found many fewer contraindications to PD compared to medical directors of in-center programs, which, I think there's this sort of relationship between knowledge impacts bias, bias and knowledge impact comfort with prescribing. And I would never want a patient in this country not to get PD because their nephrologist felt uncomfortable with it or didn't discuss it with them as a treatment option. So I'm hoping that we slowly move towards reducing that as a barrier. I don't know, Nikhil, if you have any other comments or thoughts about barriers.
No, absolutely. So we just have a paper accepted in KIR about preconceptions in especially special populations where by default, not only the discomfort in prescribing PD, but even offering PD to these people, right? So urgent starts is one of those. And the survey showed that most people are now becoming more comfortable in providing this, whether it is abdominal surgeries. People are very hesitant. I can't put in an urgent catheter because of that abdominal surgery. And there is more evidence coming out of the North American PD registry.
I was going to ask a question. I think Tim and I were talking earlier today about partnerships and how to build those alliances. And it's, I think, oftentimes easy to get nephrologists on boards with some of these initiatives, but it takes a multidisciplinary team. Can you talk about how those are built for instance, with vascular surgery or surgeons who put in PD catheters? Like, how do you get them to buy into this and prioritize it as something that, they're incentivized to, do the catheter surgeries in a timely manner, like an urgent start? Can you talk about how that happens in Canada?
Jeff, do you want to go first?
I think in Canada it's still every bit a challenge. I mean, let's face it, for many surgeons there are sexier surgeries to do, surgeries that are reimbursed much more favorably. And it sort of becomes a project that some surgeons have to take on. And I think that the key is to find somebody who's passionate, who really understands that if they don't create an optimal access, which is the patient's lifeline, they could end up coming to dialysis 4 hours, 3 times a week, and really impact their lifestyle in a negative way. And so I think a lot of it is education with our surgeons. And we have certainly developed a relationship with our surgery colleagues that, first of all, respects the fact that they certainly need to learn about the benefits of home dialysis. And they've met our patients, come to our program, interacted with us, and invite your surgeon to your Christmas or holiday party. Make sure that they appreciate how vital they are to the team. And I think that making that a part of your program and engaging with the surgeon. A lot of nephrologists have told me they've never even met the surgeon that places most of the catheters in their program face to face. And I think that's really important. And I think the North American Catheter Registry has really actually cemented the idea that we need to do QI in PD access, and we need to engage our operators. We are going to find out from the registry that there's huge variability in outcomes across the country. And I know we're not talking about KT over V yet, but a more important quality metric to me than KT over V is PD access metrics. Why can I not in this country understand when I'm educating a patient about access creation, what are the complication rates? How does that vary from program to program? And creating some degree of accountability. So I think that what we lack probably to continue to push the field forward is some accountability on the onus of the operator, and also some increased motivation of the operator, which may be financial as well. I think a big barrier is the reimbursement level of PD access. I mean, it's not just putting in a tube. It may be lysing adhesions. It may be correcting a hernia. It may be doing something called an omentopexy to help improve the patency and long-term function of the catheter. This is sort of becoming an art, and I think that it's not just throwing in a drain or a tube. And I think we need to respect that and perhaps catch up to the reimbursement level that it deserves. Because don't forget, a functional access is going to save the system, a lot of money downstream if we can allow our patients to be maintained on PD. So I think that it's all about QI engagement. And then the other thing I'll say in my program is that our surgeon was getting these referrals, and this surgeon was doing it on a first come, first serve basis. They don't know that the patient with the GFR of 5, whose potassium's been high, who's been in and out of hospital with CHF, is a higher priority PD access than somebody with a GFR of 10 who perhaps is, having a few uremic symptoms, who could probably wait a month or two to get their access. And so what was happening is our surgeon was placing them on a first come, first serve basis, not triaging them based on urgency. And guess what? If you do that, a lot of patients waiting for access may end up in hospital as a suboptimal start with a catheter. So we actually have a couple of surgeons we work with in our program. And what we do is we keep a list of, and that's, again, the beauty in Canada is we have multidisciplinary pre-dialysis care. We know all of our patients in our CKD clinics. We can actually triage and help the surgeon appreciate who needs to go first in terms of PD access. And we did a couple things. We secured OR time for the surgeon. Once a month, we added OR time that was only and restricted to PD access. And one of our nurses serves as a PD access coordinator, sees all the referrals, triages them, goes to the clinic with the surgeon, just like a sort of vascular access coordinator, and make sure that patients attend. Because the other thing, and this was, again, learning curve for me, when patients start to go to the surgeon, it's real. Dialysis becomes real. Rather than this concept you talked to them about 2 or 3 years ago, now someone has to do an operation and actually is getting them towards dialysis therapy. And when something becomes real, patients start to ask questions perhaps that they didn't ask before, because now they're thinking about it a little bit more. And they'd be asking the surgeon about what modality they should be choosing. And the surgeon would send back these patients to me and say, well, Jeff, didn't you talk to these people about modality? And I said, of course I did, but I think that it's sort of becoming real now that you're going to be doing a surgery. So our access coordinator actually attends the appointments and helps a lot with the education and sort of is that coordinator. Because if you think about it, it's CKD care is in a lot of silos. There's the surgeon, there's a nephrologist office, there's the hospital, there's a dialysis program, and she kind of helps connect the dots on these silos of care.
And I will echo that. We have replicated that and it is successful. And using one of Jeff's papers a few years ago, where he outlined the catheter insertion program and the coordinator, we've successfully replicated in our program too in the last 2 years. So it is something that is doable in the same way. And I'd like to add one more thing to that is we are not limited to surgeons putting the catheters in. We have interventional radiologists and bedside nephrologists to put catheters in with the right training. And there are programs like the PD University for surgeons, for interventionalists. There are fantastic videos and hands-on training, which helps people both for the urgent starts, but generally all PD catheter insertions.
Yeah. I want to echo that and say there was, again, another paper published just recently in KI Reports. It's the United Kingdom catheter experience. And, I think programs that are going to be setting up for success can leverage the additional surgical skills of laparoscopic catheter placement that allows you to place catheters in patients with complicated abdomens, perhaps put in presternal catheters when you have a stoma or want the exit site away from any significant abdominal scarring. So you've got that expertise for the complicated abdomens. And then you've got a sort of rapid access pathway, either a nephrologist or a radiologist who can put them in for urgent start patients or patients with comorbidities that might preclude general anesthesia. So you sort of get the best of both worlds when you have a dual access pathway in a program. And I think the US certainly has been largely surgical dominant. And a recent paper in JASON, I think using CMS claims data, has shown that the non-surgical pathways certainly are very underutilized. And perhaps the outcomes are not as good as the surgical pathways. And that's another opportunity for improvement, is to sort of really rev up nephrology and radiology based catheter insertion expertise and use in this country.
I wanted to go back to education, and I was very excited to see the partnership between ASN and Home Dialysis University. And Tim is actually one of about 100 or so fellows from across the United States that is in that program. And tell us about your experience so far.
Yeah, I think it's been a really great opportunity. I started out, I did attend Home Dialysis University, the couple of day program out in Costa Mesa, California. I actually met Dr. Perl out there. And it was great. I learned a ton, but it was a whirlwind. And there are a lot of kind of dense topics that you grasp them at the moment. Just like many things in nephrology, you get a good moment of insight, but if you don't re-access that information for a long period of time, it kind of
Like I remembered and forgot. I remembered and forgot renal tubular acidosis like 5 times.
exactly. And
Only 5.
so you get great opportunities to, like, in a pretty low stakes environment, kind of like the case-based learning you do in med school sometimes now, where you go over some cases with an expert, and you can kind of consolidate all the learning that you did at Home Dialysis University. So it really is helping with the step number 1, which is the education side of things. I will say I was struck by, you guys started with the importance of education, and I didn't really fully appreciate the idea of how educating the surgeons and helping them know your patients, how important that would be, because that does seem like a good way to build buy-in from all the stakeholders to build a program and a protocol. Because I really think now, like for me in my current state as a fellow who is interested and open to learning about how to prescribe PD, what prevents me from doing urgent start PD is no longer that knowledge component. It's now the structural component. Like, how do we get it done? How can we make it so that the path of least resistance, or at least of a reasonable amount of resistance, is to go ahead and try to do the PD? And it seems like you guys have built amazing programs for it. We are interested and hopeful to do that, and we're starting to work on an urgent start PD program, but there's a lot that goes into it, and I don't think we're quite where we want to be yet, and I know that we'll need to kind of extend that knowledge to other fields and specialties to build that buy-in.
Yeah. And, urgent start PD is one solution to suboptimal starts, or patients that come in without any education and need to think about their options and being able to facilitate PD in the acute environment. You avoid a catheter and the attendant risks of bacteremia. You certainly can start, PD, low volume supine, within 24 to 48 hours. But it's a team effort, Tim, as you said. You need to engage your administrators. It may extend length of stay by 1 or 2 days, but that will reap dividends in terms of the patient being established on a home therapy. And you need to have a solid education platform. You need to make sure that patients feel comfortable, they've been educated, and they get discharged with a support plan in place that really empowers them to, feel like they've got a team behind them that will support them to do home dialysis. And that, or really, and Dr. Ghaffari, and I know you talked about it in the write-up at Keck, really, I think, demonstrated proof of principle, economically challenging part of Los Angeles, that he could establish and start a whole PD urgent start pathway for his patients. Having said that, that's certainly one solution. And I think 100% of patients in the urgent setting should get education, should get support. And sometimes urgent start PD may not be feasible. And then patients get discharged, and they get discharged to outpatient hemo facilities. And then they get a blanket, and then they get, a water bottle, or they sit in their corner in the in-center hemo unit. And it's very difficult once someone is so scared, for this is all new to somebody, to then tell them to completely change their life and consider home dialysis. So in my mind, another gap we haven't solved is the sort of psychosocial support that it takes for somebody to make a change when they're scared, when something's new. And I call it like modality change inertia. It's really difficult to get somebody to make that change. Whereas if you start PD from the get-go, you sort of have you've avoided that sort of modality change inertia. And I think that's where, and again, we can talk about the merits of these programs. Transitional care units may fill a role where patients are discharged, but they're discharged to a program that perhaps provides them more support and education to discuss things like kidney transplantation, to discuss surgical access, to discuss home options. And certainly in Toronto and in Ontario, where I'm from in Canada, so many of these new start units and transitional care programs that provide that upfront intensive education that should have happened in CKD but didn't, to help patients think about home dialysis as an option.
Matt, before you go ahead, I have an acronym that I want to talk about from what Jeff just mentioned. So, in our transitional care unit, which we started about a couple of years ago, we call it, did you have the hashtag chat? CHAT. C is for conservative care, H is home dialysis, A is appropriate access, and T is transplant. It's catchy. Did you have the chat?
Oh, I love that.
That's great. Well, this is a good transition point. Now, I'll just make clear we have two teams here, and it's PD first versus beyond KT over V. We just put PD first because it had first in the name. But really, if you want to get some fighting going on in a bunch of home dialysis enthusiasts, it's talk about KT over V. Let's just be serious here. There's nothing that gets them more fired up than to hear about how the U.S. measures KT over V for every one of their patients. So let's talk about beyond KT over V. And Tim, why don't you kick us off? How did we choose this topic, and what exactly are the points that you're trying to get across to the readers?
Yeah, I thought it would be a good topic because it feels inherently controversial, like something that people like talking about. But it was actually kind of tricky to frame it in a way that it just didn't become a punching bag because most of the people who want to talk about it want to talk about how bad it is. Um, but I think where the challenge comes in is, you know, educating people on what the alternative is going to be. It's always easy to tear something down, but measuring how to provide great PD um, is something that is challenging, and it has a lot of different aspects to it. Um, so in the written piece, I started out kind of just giving the historical perspective on how we got to where we are with the benchmarks that we currently shoot for that would indicate quote unquote adequate dialysis, and then kind of transitioning to how we aspire to be more than adequate, how we want to provide excellent care, and how the ISPD guidelines really shift the focus towards that shared decision making side of things and the how can we describe high quality care? What metrics should we actually be using? What objective parameters are there? Because of course it's easier said than done when all the units have to be evaluated and graded in some way. Any subjective parameter is going to be, susceptible to bias. So what kind of objective things can we look at aside from KT over V? Um, and then I also included a section to kind of balance things out that we've already touched on a lot, which is how do we broaden, kind of if we open our minds past KT over V, can we think of other patients that might be a good candidate who we might have ruled out before? And they weren't being ruled out exclusively because of KT over V, but for various kind of preconceptions that you guys have already alluded to very, very well, like, the patient with an ostomy, the patient with polycystic kidney disease, or the morbidly obese patient. Can we broaden our focus of who could be an excellent candidate?
No, and that write-up was really excellent. I think you covered all the important points. We stole KT over V from hemo because we always in PD, I think, have this inadequacy complex where we feel like we need to compare ourselves to hemo. And so, hemo had a measure. Hemo developed this fancy metric to look at urea removal that sort of didn't, urea being high could be someone who's eating a lot of protein and stuff, or somebody who's not getting well dialyzed. So KT over V, developed by Gotch, was like this whole reinvention of the way to measure clearance. And we in nephrology love to measure things. And so in PD, we said, well, if they're doing it, we have to do it too. And we have to start measuring urea removal. And let's start reporting it, and let's start looking at it. And a study was developed in the United States called the CANUSA study, which was a Canadian-USA study on the adequacy of dialysis. as well as a landmark study in Mexico called the ADAMEX study, which was a randomized controlled trial. ADAMEX was in CAPD patients and actually didn't show that targeting a higher KT over V impacted outcomes. Canusa was done in the 90s, I suppose in the 90s. Bigger was better, got to crank up the KT over Vs. And a paper was published and said, aha, we found out the higher the KT over V, the better the survival of patients on PD. So everybody was like, great, we've got to now prescribe to this really high KT over V. And then my colleague and my mentor and friend, Joanne Bargman, said, wait a second, let's have a look at this data a little bit differently. Let's look at residual KT over V urea, residual kidney functions contribution, and let's look at peritoneal, and let's separate those out and see how that impacts survival. And guess what? The whole survival advantage of KT over V was driven exclusively by residual kidney function. So every time we do those adequacy calculations, and I hate the term adequacy because nobody wants to be adequate at anything. We want to be high quality. But every time we do those KT over V calculations, we make this erroneous assumption that we can add peritoneal and renal, and the contributions to patient outcomes are going to be similar. And that is just not true. Residual is so much more important. So, Tim, to answer one of your questions, residual kidney function, preservation, monitoring, and strategies to continue to allow patients to have residual kidney function over time, I think are a very important metric in our patients to track and develop strategies, hopefully stealing from some CKD therapeutics to continue to preserve even in our patients once they start dialysis. So that's one quality metric.
I just heard you want to fluosinate people on PD.
I want to study it.
Okay.
I definitely want to study it, and I know that and I have in my practice I have not stopped it. Now I'm getting my group of patients coming in, hopefully less and less, but a group of patients coming in, and we're not stopping them when patients start PD.
I really like that concept, and at Duke in the fellows room, there's a board that has like how many days have passed since I said the word Flosin.
Yeah, it had to pop up.
Typically at 1 to 0 days. So I just had to get that out there on the podcast.
Yeah.
To take it even further is when people measure KT by V and then transition the patients off PD because of that particular target not being reached, when the patient really does not have, is doing quite well on PD. And that is something that we need to be very careful about.
And even if KT over V in a hypothetical world did impact outcomes, does my 90-year-old patient on a low volume incremental exchange who's living life to the fullest, feeling great, need to be saddled because their KT over V is 1.6 and now they have to add that extra exchange or spend that more time doing PD when they could be out doing more? And really, it's not about survival, it's about quality of life and being able to participate in life's activities. So a whole other component of this is, what is the goal of dialysis care in our patients? For some, it may be survival. It may be bridging somebody to a kidney transplant. But an 85 or a 90-year-old starting on a low volume intensity prescription, we have to really sit down and say, what are the goals of this therapy? And as I say to my 92-year-old patient who's now in Florida playing golf, your golf score is way more important to me than your KT over V. That tells me how well you're doing, your ability to participate in life activities.
That's a really good point. It does bring up kind of the titratability of the PD prescription, the fact that you can tailor it so well to what outcomes matter to your patient. I think one of the challenges that I have often in patients that we have in the hospital who are ill, but they're not done fighting, you have to make this tough call, like, are we going to do dialysis or are we not? And I feel like oftentimes, like in that scenario, if they're a PD patient in your clinic, you can kind of find a middle way where it's like, okay, well, maybe you can do this minimal amount of treatment that might give you a little more time, might give you a little more quality, but it's not full bore. It's not making it the focus of your life.
Yeah. You also made me think about a point I wanted to mention is, how many times when you're rounding on in-center and you're seeing an 80-year-old patient with diabetes, a couple comorbidities on dialysis, who says they're feeling tired and a little bit unwell, that you say they're underdialyzed, and all of a sudden you say they've got to come in 5 days a week and do an extra hour because they're underdialyzed. We never go to underdialysis because we say, well, they're 85, they've got a lot of comorbidities. This may explain why they're feeling the way they do. But in PD, immediately everybody jumps to underdialysis. And I think one of the things I've realized is not all symptoms are related to the solute clearance in dialysis. There's many other reasons our patients may have the symptoms they do. And I think that's another aspect of it, is that, is this really dialysis related? How likely is it to be? And sometimes the right thing to do is to increase the dose of dialysis. But sometimes if we've done that and the symptoms persist, have we really done the patient a service by now saddling them with more dialysis?
The workload of dialysis is also something that we have to consider. And so sometimes for looking beyond KT by V, you have to think about, can we provide some assistance? An assisted PD program can really help bolster a PD numbers and provide value-based care.
And Tim, you said, what can we measure? What else can we measure? At a program level, to measure quality care, residual kidney function and its measurement, I think peritonitis is key. We are not mandated as of yet to report peritonitis and be accountable to our peritonitis rates. That, to me, I think is many more nephrologists would argue that peritonitis probably has a stronger link to quality improvement and quality care than perhaps KT over V. And we talked about PD access. So I think there's many more things at a program level we can evaluate for quality care. At a patient level, that becomes tricky. And I always, when I'm talking to people like a group of nephrologists, I'll always say, okay, you're about to hire the next nephrologist in your group practice. Okay. So Tim, you're going to be looking for a job soon? Okay.
Actively looking now.
Okay. So I have two options. I could rely on your USMLE Step 3 scores, or I could spend 2 to 3 weeks with you on the inpatient service and get exposed to your inpatient care and your interactions with patients and other colleagues. To me, that would be a way more valuable assessment of, would I want this nephrologist in my practice, than their USMLE Step 3 scores. And to me, KT over V is like the USMLE Step 3 of PD evaluation. Maybe it does have some impact, but there's so much more of a gestalt that goes to patient assessment, how they look, how they feel, what their nutrition is like, volume, blood pressure, phosphorus, again, debatable for another podcast, and so many other factors that we would want to look at to decide, is this patient thriving or is this patient struggling on PD? And to me, that's a multidimensional assessment. And maybe it isn't measurable. Maybe we can't put a number on it. But I think that it would have such a bigger impact on looking at that lens and how we evaluate individuals on dialysis than just really honing in on this one number with very poor evidence supporting it.
I want to, at least give KT over V a little bit of credit. Okay. I totally agree with that. We've given this KT over V such importance, and especially in the United States, tied to quality in PD dialysis units. But it still can be a valuable thing to know and part of the overall assessment. Would you agree with that?
Nikhil, why don't you handle this one? I'm formulating.
Are you saying throw it out completely, or still have it as something that, you want to know how well you're doing with removing urea? You want to understand and continue to measure that, or is that something we should just throw out?
As a home dialysis fellow, when I started in my program, every patient got a yearly adequate to measure the KT by V, because that was the way it was done forever. Within a year of my fellowship, I was like, this is completely useless. I do not want to do this. And we kind of started a process, and now it is only done for patients who are indicated, where there is an indication. If you look at the core outcomes that were developed by the Song PD.
So let me just get this straight. You're saying throw it out.
I would say throw it out. Yeah, I'm going to put my money on that and say, don't look at the KT over V, look at the patient.
You're not even saying don't look at it. You're saying don't even measure it.
Oh, I wouldn't even measure it. Unless there is an indication, I wouldn't measure it. And I don't.
Yeah, I don't measure it in my program either. I do measure residual kidney function, and that's really critical to track, because oftentimes a drop off in residual kidney function has to be met with an increase in the PD prescription. As part of sort of an incremental strategy, we track that really carefully. The KT over V, I think, if I see somebody whose KT over V would be 2 and they're unwell and they're feeling unwell, and I suspect clearance is an issue, I'm going to increase it, whether it's 2 or whether it's 1.7. Similarly, if I see somebody who's thriving and their KT over V would have been 1.6, I'm not sure I would necessarily augment the prescription based on that.
But neither one of y'all would even know. So
yeah, I think it can pick up big issues. I think right now the other thing that we have in our armamentarium is, someone could do an excellent KT over V in that 1 24-hour period, but never do their dialysis, or not be necessarily adherent with a prescription.
It's like brushing your teeth before you go to the dentist.
Right. Exactly. Exactly.
Well, I think, let's go back to education, and I want to tie this into it. Any question you get for board prep, you do some cases for the fellows. Almost all of them have KT over V.
Yeah.
And, it's sort of like, to me, it seems like a barrier in the United States for education, because it's like we can't get over KT over V. It's not just beyond it for quality measures. Like, it seems to be a big focus of education too.
Yeah, because it's measurable and it makes for great exam questions written by nephrologists who trained in the 70s and 80s and maybe 90s when KT over V was all the rage. And so I think it's sort of a lot of it stems from the historical aspects of where it came from. But I do think people are challenging that. I do see some pushback. I do see advocacy happening around KT over V. And I think perhaps that if we're never going to get rid of it, if that's going to be something cemented in, at least we could reevaluate where this 1.7 per week came from, and perhaps reconsider that, and relax that a bit under certain circumstances. And so it's going to be a tough one, Matt. It's going to be a very tough one it's going to be a big culture change. It's going to take a lot. And I hope that data, from studies like we did in the Peritoneal Dialysis Outcomes and Practice Pattern Study that did not show a survival benefit of KT over V, continue to empower people to reevaluate it. You know where the lowest KT over Vs are? In Japan. And you know where the significantly high survival of patients on PD is? In Japan. Now, transplantation is very low there, so that might account for that. But I really think when we look at this from a global lens, there isn't really a strong, compelling reason to retain KT over V.
Tim, I want to go to you. You're a trainee. You're going through this. You're getting inundated with KT over V case vignettes. What is your view on it? And first, is it possible to get rid of this in the United States? And how does a fellow sort of cope with this? They're going to home dialysis university and hearing this, and then they're going back home and trying to figure out how to reconcile these two things about KT over V.
Yeah, it's a good question. I think on the one hand, we are at the mercy of the boards, okay? They put it on there, we have to know it.
I just have to put a conflict of interest out that I am a member of the nephrology boards for the United States.
Did you ever write a KT over VPD question?
The good news is I'm not actually a question writer. I'm more of a policy person. But I think these are important things for the policy group to talk about and to consider, because what's on the exam then turns into what needs to be put in the curriculum. Absolutely.
Yeah, and that becomes like part of your mental note card. There's so many topics you need to understand and know as a doctor and as a nephrologist. If that's part of your, what you've committed to memory for the long term, it may influence the way that you practice. On the topic, I think it's true that it's so embedded that I think the idea of getting rid of it entirely seems a little impractical to me. I think the approach that's been taken of getting rid of its privileged position as like the sole determinant of what makes PD adequate, which we don't like as a term, I know, but adequate or not, if we can de-emphasize it but continue to measure it, I think that would probably be the best next
Yeah.
step currently, because you do have to factor in PD experts who are wonderful at tracking for things like uremic symptoms. It may not be necessary. For people with less experience or who may not be watching their patients as closely, there could be a bidirectional relationship there. Like if you're measuring something and it's what tunes you in to maybe look for something going on, like it's theoretically possible that it could be useful in that setting. Although it sounds like in your extensive experience it hasn't been. But others might need to build their experience before they feel comfortable making a jump like that.
Yeah, and I just want to point out, I think those are great points, Tim, and it's baby steps. A really great article to read, which I found very insightful, and I think really highlights the essence of what you just said, is the 2020 commentary, the KDOKI commentary in AJKD on the ISPD guidelines. So written by American nephrologists that put the guidelines in the perspective of US dialysis care. So it really, I think, highlights a lot of what you said. I would encourage people to have a look at that, and I think it gives people a little bit of a roadmap of how to practice. And I think if there's a philosophy change, and if nephrologists understand that it's not the be all and end all, there's many other things, and they put it in the context of one aspect of measurement of care and de-emphasize it, I think that's a step in the right direction. The other thing that I think, Tim, you said in the write-up, which is really interesting, is urea is distributed in water-soluble tissues, not in the fat mass. So if we have patients with elevated BMI who we know already people have biases against PD for, then the KT over V, that V becomes, if you use their actual body weight, it's a much larger V. And guess what? That makes the KT over V a lot smaller. So I don't have the right answers, but I can certainly say that in this country, many KT over Vs are being reported standardized to what we think is the volume of distribution of urea of that patient, which it is not if we're using the actual body weight, particularly with significant adiposity.
Which is a broadly applicable thing for our population.
Well, we're getting towards the end, and this is the point where we've heard about the pluses and minuses of each of these topics, and we need to put our money down and say, like, which one is the blue ribbon panel going to pick as the winner of NephMadness? And there's two ways. There's actually three ways to go about this. One is try to get into the head of the blue ribbon panel, which we haven't released who they are yet, but our listeners will. So we don't, know who that blue ribbon panel is. We need to get into their heads. I will say that if I'm thinking correctly, we don't have any major PD gurus on that group. Okay. The second is to pick your home team. It doesn't matter. Your team's going to win. That's the home team. And the third is just to pick based on the uniform. If you like how the uniform looks, that's what you're going to go for. And I'll say that when you're picking teams for NephMadness or March Madness, each of those three ways has merit. Okay. You can win, doing any of those things. So let's go ahead and get this started off. And I think as the fellow in the group, I want Tim to go first. Who are you going to pick? Is it going to be PD first or beyond KT over V?
All right. Well, I think there is a pretty strong case either way. And this gets to the core of, took me a while, just like Dr. Perl, to understand what NephMadness is about. But my understanding is it's about the biggest impact on patient care in the next 5 to 10 years.
But the blue ribbon panel has to be the one that determines that.
Yeah, but I think if they really think about it, they'll conclude that PD first is going to have a bigger impact in the next 5 to 10 years because it reflects big structural changes in how dialysis is being reimbursed and how we're trying to get to these really lofty goals. I think there's a lot of action on this topic.
So you're choosing the topic based on getting in the head.
I guess that would be what I'm doing. I'm getting in my head, but I think that'll have a bigger change in the way that we're taking care of patients. I think while moving past KT over V is important and a change that we need to do, I think a lot of quality PD providers are already kind of factoring this in. They're saying, KT over V is not 1.7, but they're doing great. I'll take the hit hypothetically. So I think that the way that they're providing care may have moved beyond what the board question says already.
So you say we've already moved beyond KT over V. Just not in the boards, not on the board exams.
From my limited experience of talking to people who do home dialysis university, they certainly have, and so my sample is probably skewed. But
Okay. All
that
right.
that is
Fair
my
enough.
pleasure.
So we've got one vote for PD first. Well, I guess we'll move ahead to Nikhil.
I'm completely biased here. I am always going to be for Beyond KT by V
Oh wow.
because again, the Blue Ribbon panel is US based, and they really need to know that
Oh,
KT
that's not
over V.
100% true. It's not we do
Okay,
have there's a UK member
okay.
of the Blue Ribbon panel,
Oh,
and
there are some sensible members. Ah, that's nice. Trash. We have to have trash talk.
well, yeah. Well, hopefully this is more international than US based listenership.
My money is on Beyond KT by V.
Oh
100%.
wow. I mean, it's like he doesn't even measure it, so like obviously, you know. I want to let Jeff go last because I think he has the most opinions about this. Oh, man, I've been going back and forth, and usually I find something and really go after it. And I know part of me wants to go after KT over V because, oh man, it's like just fun to just pounce on it. And Beyond KT over V sounds exciting. But I think being in the United States and seeing the structural problems with getting people to get on PD first and the inertia that happens when you get someone on dialysis and it's just hard to make those changes. I think you're right, Tim. PD first is going to make the biggest impact. And I think I'm going to pick it not because I'm getting in the head, but I think it's the right thing to do. And I think it's the home team for me. So I'm going to go with PD first. So, Jeff, for PD first, one for Beyond KT over V. Are you going to be able to make a decision?
I think that nothing gets my heart rate up and nothing gets me more impassioned than to do a good old fashioned KT over V bashing.
I could feel it.
Because I do feel passionately that it is not a marker of high quality dialysis. Having said that, when I look at the landscape of dialysis care, and I think very similar to Tim's arguments, when I look at where we really need to be, yes, KT over V hopefully will naturally evolve on its own as we put more patients on PD to realize what really is important, and we gain that experience and expertise. With that knowledge, I hope that KT over V will naturally become de-emphasized as we see incremental PD take off and patients continue to do well and more comfort with PD among more nephrologists. But I think the only way to get there is PD first. So I'm going to say, I'm going to use a little bit of that logic you said, what the Blue Ribbon panel's thinking, what I think will have the biggest impact on care, where I think we need to be, where I think we might be heading. I'm going to say that I'd have my money on PD first. So I'm going to
There
be.
is there is a nice analogy about PD programs. There is a bathtub with water flowing in and a drain going out, right? Yes, water flowing in is your PD first, but if you keep looking at KT over V, the drain in the patients moving away from that modality is also equally important. So I think it's a tough cage match, but I'm going to stick to my guns.
Well, thank you so much for having us on. And, we want to increase the number of people that play NephMadness and learn and debate. And I think one of the things that I've loved about being involved in free open access medical education in the international space is learning about how medicine is practiced outside of your own bubble. And I think that's really important for everyone to always, sort of get out there and learn about not just how it's happening in your local community, but how things are happening everywhere. So you can go to www.nephmadness.com, submit your brackets. You have the entire month of March to do so, and see if you have what it takes to win Neph Madness, and prizes, and more importantly, bragging rights are at stake.
I'm super excited to see how this plays out. Hopefully, on social media, we'll have a lot of discussion about this among our PD colleagues.
We have a button that says no baclofen in CKD, and I want to get a button for you. Next time I see you, it's going to say, no KT over V in PD, and it's kind of an X across it. I'm going to hand that to you at the next
Oh.
kidney week.
Oh, well, maybe we can hand it out to everybody.
I can handle it out to everybody.